The termination letter felt heavier than it should have. Not because of the weight of the paper, but because of what it represented. 8 years of my life, dismissed in a single conversation. Gerald Hawthorne, my new boss of 6 months, slid the document across what had been my desk for nearly a decade. "I'm sorry it's come to this, Cornelius," he said, his voice carrying what seemed like genuine regret. "But we need people who can adapt to our new operational realities. My name is Cornelius Langford, and I'd been head of quality control at Pinnacle Pharmaceuticals since 2016. 8 years of 5:30 a.m. arrivals, reviewing overnight manufacturing reports, believing that the work we did mattered. And maybe that was my mistake, believing that doing the right thing would always be enough. What I didn't know then was that this moment would become the catalyst for the most important fight of my career. Not just for my job, but for the lives of thousands of diabetic patients, including my own sister. Let me tell you about Pinnacle Pharmaceuticals, or at least the company I thought I knew. For 7.5 years, it felt like we were part of something meaningful. We manufactured life-saving insulin for diabetics across the country. Every batch we produced, every safety protocol we followed, represented someone's father, mother, child who depended on us to get it right. Then Gerald Hawthorne arrived as our new VP of Operations. Now I want to be clear about something. Gerald wasn't a cartoon villain. He was smart, articulate, and genuinely believed he was doing what was best for the company. He had an MBA from a prestigious university, years of experience in operational efficiency, and a mandate from corporate to improve our bottom line. In our early meetings, his concerns seemed reasonable. "Cornelius, I've been reviewing our quality control processes, and I think we might be over-engineering some of our safety margins. The FDA requirements are clear, but we're going significantly beyond what's legally required. That's expensive." He wasn't wrong about the costs. Our quality standards were rigorous, sometimes beyond what regulations strictly demanded. But there was a reason for that. In pharmaceuticals, there's no such thing as good enough when people's lives depend on your product. I tried to explain this to Gerald. The thing is, insulin isn't like other medications. Diabetics don't have alternatives. If our insulin fails, they don't just get sick, they can die within hours. "I understand that," he said, "but we also have shareholders to consider. We can maintain safety while improving efficiency. It's not an either-or situation." And honestly, I wanted to believe him. Change is hard, and I'd been doing things the same way for years. Maybe there was room for improvement. Maybe I was being too rigid. That willingness to consider his perspective, it nearly cost people their lives. The changes didn't happen overnight. That's what made them so insidious. It started with small things. Inspection timelines shortened, documentation requirements streamlined, testing protocols optimized. Each change, taken individually, seemed minor. Gerald presented them as improvements, backed by data and efficiency studies. But I started noticing patterns. Quality issues that would have triggered immediate investigations were now being categorized as within acceptable variance. Batches that I would have held for additional testing were being approved for shipment. When I raised concerns, I was told I was being overly cautious or resistant to change. The breaking point came with what we internally called the Tuesday meeting. Gerald had called together the department heads to discuss our quarterly performance. We were behind on shipping targets, and the pressure from corporate was mounting. "I need solutions," Gerald said, looking around the conference room. "We're missing our numbers, and that's not acceptable." Hannah Lee from manufacturing spoke up first. "We could reduce the cooling time between batches. That would save us about 6 hours per production cycle." "How much would that impact quality?" I asked. "It's still within FDA guidelines," she replied, though her voice carried a hint of uncertainty. Tom Rodriguez from packaging suggested reducing the number of random sample tests. We're testing 5% of each batch. The FDA requires 2%. We could cut our testing time in half. I felt my stomach tighten. Those additional tests have caught problems before. Real problems. Gerald leaned forward. Cornelius, what problems specifically? In the last year, how many batch rejections came from those extra tests? I had to think. 3, maybe 4. Out of how many total batches? About 200. So we're talking about 2% of our production. And what was the nature of those problems? This is where it gets complicated. The issues we'd caught weren't dramatic, slightly elevated bacterial counts that were still within FDA limits, potency variations that were technically acceptable but at the high end of the range. Nothing that would have immediately killed anyone. But here's what Gerald didn't understand, or chose not to understand. In pharmaceuticals, those small variations compound. A diabetic patient injecting insulin with slightly elevated bacterial counts might not have problems the first time, or the 10th time. But over months, years, those marginal quality issues become significant health risks. I tried to explain this, but Gerald's response was rational and persuasive. We can't let perfect be the enemy of good. We have obligations to our shareholders and our employees. If we can't compete effectively, we help no one. The room was quiet. Other department heads were nodding. Gerald's argument made sense from a business perspective. I was the only one pushing back, and I was starting to feel like the problem. That night, I went home and looked at my sister Sarah injecting her evening insulin, the same insulin we manufactured. And I realized that every compromise we made in that conference room was a compromise with her life. The moment that changed everything came 3 weeks later with batch number 47,291. During routine testing, I discovered something troubling. The insulin potency was degrading faster than normal. Not dramatically, but enough to be concerning. Instead of maintaining its effectiveness for the full shelf life, it was losing potency about 20% faster than it should. Now, let me explain what this means in practical terms. A diabetic patient calculates their insulin dose based on the expected potency of the medication. If that potency is lower than expected, they're essentially underdosing themselves. Over time, this can lead to hyperglycemic episodes, dangerous spikes in blood sugar that can cause coma or death. The batch represented 400,000 vials of insulin. I brought this to Gerald immediately. His office had a large window overlooking the production floor, and I remember watching workers packaging vials while I explained the situation. So what you're telling me, Gerald said, reviewing my test results, is that the insulin is still effective, but for a shorter period than labeled. That's correct. Instead of maintaining full potency for 18 months, it's only maintaining it for about 14 months. And this affects how many patients? Potentially everyone who uses this batch. If they're relying on the labeled expiration date, they could be injecting insulin that's significantly less effective than they think. Gerald was quiet for a long moment, staring at the numbers. What's the worst-case scenario? Diabetic coma, death. It depends on the individual patient's health status and how much they're relying on this insulin to manage their blood sugar. And if we recall the batch, we investigate the production process, we figure out what went wrong and fix it. Cost? I'd already run the numbers. About $3.2 million, plus the cost of the investigation and process improvements. Gerald rubbed his temples. Cornelius, I need you to help me understand something. This insulin will still work for 14 months, correct? Yes, but... And most patients use their insulin within 30 days of purchase. Generally, yes, but some people buy in bulk and... So we're talking about a small subset of patients who might be affected, and only if they keep their insulin for more than 14 months. The way he framed it made my concerns sound almost paranoid. But that's the insidious thing about pharmaceutical risks. They're often statistical rather than immediate. It's not like a car with faulty brakes that will definitely crash. It's more like a car with slightly worn tires that might skid under certain conditions. Gerald, we can't gamble with people's lives based on statistical probabilities. We're not gambling, he said. We're making risk assessments. That's what pharmaceutical companies do every day. Every medication has risks. Every business decision involves weighing those risks against benefits. I left his office feeling frustrated and uncertain. Was I being overly cautious? Were my concerns legitimate? Or was I just resistant to change? That evening, I did something I'd never done before. I started documenting our conversation. Not because I planned to use it against Gerald, but because I wanted to track the decision-making process. If something went wrong, I wanted to understand how we'd gotten there. It was a decision that would eventually save thousands of lives. Over the next few months, I started paying closer attention to our decision-making processes. Not with any grand plan, but out of professional curiosity and growing unease. What I discovered was a pattern of incremental compromises. Nothing dramatic, nothing that would trigger immediate regulatory action, but a steady erosion of our safety margins. Gerald wasn't deliberately trying to hurt people. He was trying to save a company that was struggling to compete in an increasingly challenging market. Every decision he made had a rational business justification. The problem was that those rational business decisions, when aggregated, created real risks for real people. I started keeping more detailed records, not recordings initially, just notes about decisions, rationales, outcomes. I told myself it was professional development, understanding how business decisions were really made at a corporate level. But I was also thinking about Sarah. Every evening when she injected her insulin, I wondered, was this one of our batches? Had we compromised on something that might affect her? The abstract concept of patience was becoming very personal. The wake-up call came when I received a letter from a diabetic patient in Ohio. She'd experienced a severe hyperglycemic episode after using one of our insulin batches, one that had been approved despite my concerns about potency variations. Her letter wasn't angry or accusatory. She just wanted to understand what had happened. "I've been diabetic for 15 years, she wrote. "I know how to manage my condition. But this insulin seemed different, weaker. My blood sugar readings were consistently higher than normal. My doctor had to adjust my dosing. I'm wondering if there was a quality issue with this particular batch." I researched her batch number. It was one of the ones I'd flagged for additional testing that had been streamlined away in the name of efficiency. The potency was within FDA guidelines, but at the low end of the acceptable range. That letter made me realize something crucial. Our decisions weren't theoretical. They affected real people with names and faces and families. People like Sarah. People like me. I started recording conversations. Let me be clear about something. I didn't set out to destroy Gerald's career. I started documenting conversations because I was genuinely trying to understand how pharmaceutical companies balance safety and profitability. I thought if I could understand the decision-making process better, maybe I could find ways to improve it. But as I accumulated evidence over the following months, a disturbing picture emerged. It wasn't just about cutting corners or improving efficiency. There was a fundamental disconnect between how Gerald talked about patients in public versus private settings. In board meetings and public statements, he spoke eloquently about Pinnacle's commitment to patient safety. But in private conversations with department heads, the language was different. Patients became end users. Safety concerns became regulatory obstacles. Quality issues became acceptable variances. The most damning conversation came in January. Gerald was meeting with our financial team about quarterly projections, and I was there to provide quality assurance data. The bottom line, Gerald said, is that we're in a competitive market selling to a captive audience. Diabetics don't have alternatives to insulin. They'll use whatever we provide because they have to. Our job is to provide a product that meets regulatory requirements at a price point that maximizes shareholder value. When someone asked about patient satisfaction, Gerald's response was telling. Patient satisfaction is a luxury we can't afford right now. Patient compliance is what matters. They keep buying our product because they have no choice. That conversation made me realize that Gerald genuinely saw diabetic patients as a captive market to be exploited rather than vulnerable people to be protected. It wasn't evil. It was worse. It was complete moral indifference. I knew then that I had to act. Not for revenge, but for protection. Protection of patients who trusted us with their lives, and protection of employees who still believed in the company's mission. The final straw came with my termination, but not in the way you might expect. Gerald didn't fire me for insubordination or poor performance. He fired me because I had become a cultural fit issue. My persistent questions about safety margins and my resistance to operational changes were creating negative team dynamics. I'm not questioning your competence, he said during our final meeting. You're excellent at your job, but this company is evolving, and we need people who can evolve with us. The termination was handled professionally. Generous severance package, positive references, even a personal recommendation from Gerald for future opportunities. It was clear he respected me and genuinely believed he was doing what was best for the company. But that night, sitting in my home office, I realized something. Gerald's rational, business-focused approach to pharmaceutical manufacturing was going to get people killed. Not immediately, not obviously, but inevitably. The evidence I'd been collecting wasn't just documentation anymore. It was a weapon, and I had a choice. Use it to protect patients, or let it gather dust while people like Sarah trusted their lives to increasingly compromised medications. The choice was easy. The execution would be harder. Building a case against a pharmaceutical company isn't like exposing a simple fraud. It's not enough to show that rules were broken. You have to demonstrate that patient safety was genuinely compromised, that the company knew about the risks, and that they chose profits over protection. I spent 3 months organizing my evidence, not just the recordings and documents, but the context that would help regulators understand the pattern of decision-making. Each seemingly minor compromise had to be connected to potential patient harm. Each business justification had to be weighed against safety obligations. The hardest part wasn't technical, it was emotional. I wasn't just whistleblowing on abstract corporate wrongdoing. I was potentially destroying the careers of people I'd worked with for years. People who, like Gerald, genuinely believed they were doing their jobs competently and ethically. But every time I wavered, I thought about that letter from Ohio, and I thought about Sarah, trusting her life to medications that were being manufactured under increasingly compromised standards. When I finally walked into the FDA field office, I brought more than just evidence. I brought recommendations for systemic changes that could prevent similar problems at other companies. I brought suggestions for improved oversight mechanisms. I brought solutions, not just accusations. Special Agent Jennifer Martinez reviewed my materials for 2 hours before speaking. Mr. Langford, this is comprehensive. But I have to ask, what outcome are you hoping for? I want Pinnacle to go back to manufacturing medications as if patients' lives depend on them, because they do. And Mr. Hawthorne? I want him to understand that pharmaceutical executives have moral obligations that go beyond shareholder value. If that means facing consequences for his decisions, then that's what needs to happen. The investigation took 4 months. During that time, I started my own consulting firm, specializing in pharmaceutical quality assurance. My first client was a startup that had heard about my reputation for rigorous safety standards. They didn't want someone who would help them cut corners. They wanted someone who would help them avoid the problems that had plagued larger companies. Gerald's arrest made national news, but not because it was dramatic or sensational. It made news because it represented something larger: accountability in an industry where abstract decisions have life and death consequences. The charges were serious: conspiracy to distribute adulterated drugs, fraudulent labeling, and corporate endangerment. But Gerald wasn't portrayed as a monster in the media coverage. He was portrayed as a competent executive who had lost sight of his fundamental obligations to patient safety. During the trial, something unexpected happened. Gerald's defense attorney called me as a witness, hoping to establish that the quality issues weren't as serious as prosecutors claimed. Under cross-examination, I was asked to describe Gerald's character and competence. Gerald Hawthorne is intelligent, articulate, and genuinely committed to corporate success, I testified. He's also completely disconnected from the human consequences of his business decisions. He's not evil. He's indifferent. And in the pharmaceutical industry, indifference kills people. The conviction came with a 2-year sentence, substantial fines, and a lifetime ban from the pharmaceutical industry. More importantly, it led to industry-wide changes in oversight and accountability for quality control decisions. Pinnacle restructured its operations, brought in new leadership, and implemented comprehensive quality assurance protocols. They didn't just recover from the scandal. They became a model for how pharmaceutical companies should operate. Gerald, after serving his sentence, found work in a completely different industry. From what I've heard, he's doing well and has gained a deeper understanding of how business decisions affect real people. Sometimes consequences are educational rather than just punitive. Looking back, I realize this story isn't really about whistleblowing or corporate corruption. It's about the challenge of maintaining moral clarity in complex situations where good people can make harmful decisions through incremental compromises. Gerald wasn't a villain. He was a competent professional who gradually lost sight of the fundamental purpose of his work. The scariest part wasn't his malice. It was his rational, business-focused approach to decisions that affected vulnerable people's lives. My consulting firm now works with pharmaceutical companies to maintain that moral clarity. We help executives understand not just what they can do legally, but what they should do ethically. We help quality control professionals speak up effectively when they see problems developing. The work isn't about finding villains to destroy. It's about helping good people make good decisions when the stakes are literally life and death. Sarah still uses insulin daily. Now she uses insulin manufactured by companies that prioritize patient safety because they understand that their moral obligations extend beyond regulatory compliance. That's not just good ethics. It's good business. Every evening when she injects her medication, I'm reminded that pharmaceutical manufacturing isn't just about chemistry and business strategy. It's about trust. Patients trust us with their lives. That trust is sacred, and it requires constant vigilance to maintain. The documents I compiled during those difficult months aren't just evidence of past problems. They're a reminder of how easily good intentions can drift into harmful indifference, and how important it is to have people who are willing to speak up when that drift begins. Today, I run a consulting firm that helps pharmaceutical companies maintain the highest standards of quality and ethics. Not because they're required to, but because they understand that patient safety is the foundation of everything we do in this industry. Every conversation I have with pharmaceutical executives, I think about Gerald. Not with anger or satisfaction, but with a determination to help good people avoid the mistakes that led to his downfall. The pharmaceutical industry saves millions of lives every year. We have the privilege of working in a field where our professional competence directly affects human welfare. That's not just a job, it's a calling. And sometimes, honoring that calling requires the courage to speak up when others are losing their way. Not to destroy careers, but to save lives. Not for revenge, but for responsibility. That's the lesson I learned from the most difficult period of my professional life. And it's the lesson I hope to pass on to the next generation of pharmaceutical professionals who understand that their work is literally a matter of life and death. Thank you.